refugees, and she'll tell us a little bit about that journey. Her undergraduate was at Wheaton College in philosophy. So for those of you who are thinking of medicine, you know, the field's wide open.
That's right. Major in anything.
Life will take care of the rest. And I know Janelle has a beautiful voice and sings in the choir at St. Mark's Cathedral. And her husband has been chair for a long time in the English department. And here in the STU for a long time. And Mark Walhout. Okay.
Okay, good.
And
Thank
so
you.
these students are all are here, and maybe more will come. They're 23 usually. Two I know have other. Brooke is has a job interview, I think, at Field Relief. So
Oh, good. I'm going to mention one.
so most of them are seniors
Okay.
in global development.
Okay.
There you go.
Well, I'm really excited to be here. Thank you. I'm so impressed at your technology. I am a neighbor here on North Queen Anne, so I just walked down, which is great. I've known Mary for a long time, Professor Mary. And 30 years in the community clinics. We'll get to what the community clinics are later and how they intersect with global development. And 20 years there, I was doing refugee health, and 10 years and currently doing homeless health. So our first slide here illustrates why I was able to do 20 years of refugee health. You can see that Seattle is number 5 for for refugee rank, and has similar populations to some cities that are much larger than our own. You know, Chicago is probably 16 times as big as we are, and we had almost as many refugees settled here in 2000, so that's a very old slide.
And I can move it to the next slide.
All right, next slide. So have people seen this social development determinants of health table from the World Health Organization? See some nods? Yes. This is up here as a framework for thinking about factors that influence refugee health. And you've had probably other refugee lectures, but a refugee quick definition is someone who's fleeing danger and has left their home to do so. So let's look at those together. Are there certain domains up there that would pertain to, that are affected, that refugees are affected by, that might influence their health? Speak up. Well, they lost their housing. They have no employment or income. They go to a place where the language is different from the language of their birth. They were probably spending some time on a journey from where they lived. They're hungry, haven't had health care. They lost their entire support system. Basically every column, right, for refugees. And we can think of some examples. So say you're walking from Rwanda with your baby. There's no clean water, you're eating grubs and leaves, baby's undernourished, baby has diarrhea. You get to the refugee camp and, well, we'll make it an older child because it's a child that has to go to school. That child's not going to learn well in school, right? Because all of these things are so incredibly interconnected. And it goes the other way around too. So if you don't get very far in school, say you live in a country where you have to pay school fees, you only get to 2nd grade, your health status is going to be much poorer than somebody that finished high school. This is true in the United States too. We're talking global, that includes the United States. That's why there are free breakfasts and free lunches for poor kids, because they'll learn better. And those kids who drop out of high school in the United States, they can have a much poorer health status. Much more likely to smoke, to be obese, to not have good health literacy. They're just going to die earlier than other people who finish school. So I'm interested to hear how this table relates to what you're studying in global health. Are the Is that the exact, or a global development? Is this like the exact outline of what you study in global development? No? How does
This
it-
is a really
how does
great
it differ?
framework. It's a really great framework because we haven't looked at that. No, we haven't looked at it.
Yeah.
We looked at other things. We've looked at a lot of how organizations, like USAID,
Mm-hmm.
have, what they're doing in terms of global
Yeah.
development, some
Yeah.
of the programs. And today we're looking at maternal health and sort of some of the interventions to keep women alive
Yeah.
and children alive. So this is very useful, but this is new.
And I think it probably misses some things, basic public health things like clean water and toilets. Why don't we do the next slide?
Great.
All right, I'm going to talk about community clinics. Community clinics are nonprofits set up to address the health of a particular community. And examples in Seattle would be the CMAR clinic systems are set up to have good language access for Hispanics or people who speak Spanish. The International Community Health Center is set up to help, probably 40, 50 years ago, to help elderly people from East Asia, Chinese, Vietnamese retirees. The Odessa Brown Clinic in the Central District for African American populations in the Central District, and my own organization, previously called Puget Neighborhood Health Center, is now called Neighbor Care, set up to serve people who live in the public housing. And the principles for the community clinics reflect, I imagine, what a good NGO does internationally. And that might include doing very thorough needs assessment. For example, for the community clinics, it would be how many buses do you have to take to get to a clinic? Or where is there the greatest disease burden? Or where is there the most poverty? Which neighborhood has no clinic and you have to take 3 buses to get to a clinic? That kind of statistical needs analysis. But then even goes deeper and asks the users what their perceived health needs are in their community, how they would like that care administered. And one of the requirements of our funders is that greater than 50% of our board of directors needs to be our own clients.
Interesting.
So has your class talked about non-governmental organizations and successes and failures and why those happen?
We've talked about NGOs.
Yeah.
In their role.
So I'm just reading this Bill Gates toilet article, and that's a perfect example. If you have a little short-term mission group and you go build a toilet somewhere and you come back 20 years later and nobody's using the toilet. It's all broken down, it's full of trash, because you didn't do the needs assessment. Nobody understood how a toilet's going to affect their health. Nobody's used to using the toilet. There's no maintenance set up. And so that's, community clinics will reflect those ideas that you have to be integrated into the community, you have to listen carefully to the community, you have to continually listen to the community. There's a lot of clinics in the Seattle area, for-profit, nonprofit, but the community clinics make a special effort to address barriers to care, and that might be language, that might be transportation, income, insurance, poor mental health. And I'm proud to say the staff at the community clinics reflects the communities where we serve. So this is my team from a good 15 years ago. And you got Cece, the African American medical assistant, me, the Euro-American provider, Julia, the Lebanese American nurse, and Chow, the Vietnamese American PA student.
Really diverse.
Yeah. And it's good to have the staff look like the community. That helps with people's comfort and trust. And it also helps for cultural interpretation for those of us who are not in the community. And by cultural interpretation, that could include things like, why does that mother not want me to touch that baby's head? Why will a Somali woman during Ramadan refuse pelvic exam or blood draw? What are people's belief systems? Much of the population I took care of, their belief systems were highly eclectic. They were just looking for whatever would work. So if you got a rash or a fever, you might go to the Chinese herbalist first in the Rainier Valley. And then you might do a ceremony where you sacrificed a chicken. And then you might come see me. Most of the staff are not healthcare interpreters that require special training. So next slide. So this is a map of Seattle by zip code. And I had trouble finding sometimes refugee-specific information, so this is going to be kind of a proxy. You can see that the Rainier Valley, which I don't know if all of you are Seattleites, but this blue stripe down here, Rainier Valley, has the highest proportion of people who are not born in the United States, and you can see in the right-hand map has the highest proportion of households that do not speak English as their primary language. And you could look at...
Where is that area?
It's the Rainier Valley.
Oh, Rainier.
Yeah.
That's south, isn't it?
Yeah, right down here.
Near Columbia City?
Yeah, near Columbia City.
Yeah, it has the most diverse zip code.
Yes, and my own clinic served over 40 language groups.
Wow.
And if you looked at this map, this is Census Bureau information from, I think, 2010. But if you looked at another zip code map like this for where the poorest performing elementary schools are, or where the poorest access to vegetables is, or the lowest life expectancy, or the most smokers, they would just all totally overlap each other. It would look almost exactly the same. So people who come from another country, who are displaced, who have lived through incredible trauma, are going to have poorer outcomes. And it just shows the interconnectedness of everything related to the social determinants of health slide. That education and nutrition and health status, they're all intertwined. You can't pull them apart. All right, another slide.
Okay.
Okay, the bar graph on the left shows where refugees came from to Washington State. And I was pretty surprised by this because this does not reflect what I saw doing refugee healthcare. And then I remembered that where refugees settle and what countries they come from reflect a United States policy, reflect the resettlement agencies that helped support them while they got settled in. And that's where I was going to mention World Relief is one of them, International Refugee Committee, IRC, and then almost all denominations have a refugee resettlement arm. So a lot of support from churches oftentimes to get refugees resettled. The violet bars on the far left in the 80s or 90s are Vietnamese population, kind of reddish purple. And in our clinic we saw a lot of Vietnamese refugees who left often by boat to refugee camps in Thailand during and after the Vietnam War, mid-60s to mid-70s. My own Vietnamese population was lots of elders and moms and babies, and at one point I realized I was seeing almost no men, and they'd just all been killed in wartime. And the few middle-aged men I had on my panel, maybe about 3 or 4, they'd all been tortured as prisoners of war. And that was not something they told me for years. And I might see a guy for shoulder pain over and over, and it turned out he hung from his arms in a prisoner of war camp. And then the populations I really specialized in are hardly visible there. They're in other, a little tiny blue stripe above the violet, and that would be Laotian Hill Tribe people, the Hmong and the Mien, and the Cambodians. I was surprised how small that was compared to the Vietnamese refugees, because I knew probably thousands of people with that background. The Laotian Hill Tribe people, well, I'm not sure how much history you're doing in your major, but Vietnam War was all part of the Cold War and keeping communists out of Southeast Asia and the domino theory. And so Laos is north of, is the northern part of the Southeast Asian sort of peninsula area. And they were just, the United States was just really afraid that Chinese communists were going to come sweep down and all those countries would become communists. So they supported guerrilla fighters way up in the mountains who they thought were anti-communists, and that would be the Hmong and the Mien tribes. And those people fought doing guerrilla warfare, and then oftentimes their villages were destroyed, and they'd go to a refugee camp, and they very strongly felt they had been promised transport to the United States because of what they did for us, but most of them didn't come until the 90s, which is like 15 years later. And what you should know about that guerrilla warfare in Laos is that the United States signed a treaty saying that we would not be involved there, and that's why it's called the secret war in Laos, because we trained people and gave them munitions and airplanes and whatever. Cambodia got involved with things around the same time because the Ho Chi Minh Trail, where there were people and equipment coming from the north to the south in Vietnam, went right through the eastern part of Cambodia, because Cambodia kind of bulges out into Vietnam. And so the United States started bombing there, trying to interrupt the Ho Chi Minh Trail in the early 70s. And that and multiple other factors led to the rise of Pol Pot, the Khmer Rouge, this Cambodian communist group that then entirely destroyed the country with starvation and forced labor and genocide. And so some of those people ended up in Seattle as well, Cambodian Americans.
So what was the relationship then between our effect in terms of Vietnam and Cambodia, and then what happened with the rise of the Khmer Rouge? And do you know?
I'm sure that's, I just spent a lot of time reading about Cambodia because we visited there in January. The bombing that the Americans did, including like civilians and hospitals because of accidental strikes, contributed to destabilization, but that was not the only reason why there was the rise of the Khmer Rouge.
Mm-hmm.
Yeah.
I visited Vietnam about a year ago, and I did a lot of reading while I was there too, because you know about it, but being there is different. And I thought of all the countries to say we're going to make a stand to stop communism, we were never going to win in Vietnam, because it was they had been occupied by the Chinese, and when they got that opportunity at the end of World War II, there was sort of a window, about 3 weeks, where nobody was in charge, and they were waiting for peace agreements to be signed, and they declared their independence. And it was like they were never going to, we would fight to the last person. And somehow we just, we should have picked another country we could do something like that.
Yeah.
That was one sense. I don't know.
Well, Cambodia is historically very, very poor and was a French colony protectorate for a long time, so it was recovering from colonialism.
So they're not even up here.
So you notice that purplish red color peters out in the early 90s. the Thai refugee camps closed in 1992, and people were required to go back to their home country, even if there was nothing left of where they had been. And then I saw some very interesting special populations, 92 to 95, including a discriminated against group, which is children of American servicemen. So if you looked obviously half Caucasian, half African American, and you lived in Vietnam, you were shunned. So they had a special visa to come to the United States. There's a teeny bit of pink in the 90s for Ethiopia, related to famine and a civil war between Ethiopia and Eritrea. And Eritrea gained independence in 1992, and there have been scattered violent episodes along the border there since then. Eritrea is still starving. The bluish color for, no, it's kind of greenish for Somalis. Surprised me as well, because it's just a tiny stripe, and that's the majority of the care, refugee care that our clinics are currently doing. And that's due to Somalia essentially being a failed state for 20 to 30 years, no central government, no rule of law, just nothing, just violence and warlords.
Gangs. Gangs,
yeah. And then the most recent groups, I don't see it all anymore because I'm doing homeless health care. For instance, Bhutan surprised me that it got its own stripe. And someone, when I was helping out at a clinic, a Bhutanese patient explained to me that was due to an ethnic minority that's persecuted.
That was in Bhutan.
So Bhutan, the happiest country in the world, still hates a certain ethnic minority whose name I don't know.
That's so interesting because both Burma and Bhutan are, these wonderful Buddhist countries.
Yeah.
And then they don't have tolerance for the minorities.
Yeah.
Because if you look at the Rohingyas.
Right, and so Burma's on there as well. There's a strike for Burma. And if you look at that giant darker purple, former Soviet Union, that one shocked me as well. And then I really realized that many of those people preferred to go to the east side, and I don't know why. And just a little personal anecdote is that for a while in the Rainier Valley we were seeing Ukrainian Pentecostals who were persecuted for being Christians. And I thought, as a Christian, this might be somewhere where we could have some common ground, and that was just not true at all. Many of the people who came from the former Soviet Union believed that the community clinics were the government, so they distrusted us, they stole stuff, they just thought that was the way you interact with the government, which is learned behavior from where they came from. And they were highly suspicious of immunizations and any medical intervention, and there were court cases, probably late 90s, early 2000s, for Ukrainian Pentecostal parents who refused to treat children who died of meningitis. And so it was really kind of a culturally humbling experience for me. And then they all left and moved to the east side, so we don't see them anymore. But the other thing I noticed about that darker purple is just the political aspect of who we let into the country. And when you heard your immigration lawyer talk, I'm not sure how long ago.
Not too long ago.
Not too long ago. I'm not sure if she touched on this, but remnants of the Cold War, that we think that the people from the former Soviet Union countries are the most persecuted. And this graph does not include like people who died in genocide in Rwanda and Burundi, or people involved in the Sudanese Civil War and the lost boys, like 12-year-olds who walked hundreds of miles to Kenya. They're not on there. So, It just depends on US government policy, who comes in under what program. And then the other thing that shocked me is there's no color for Central American refugees or Mexicans. And the US is deeply divided about whether people who are in danger because of gangs and drug warlords, whether they're refugees or not. So that's, whether they qualify for refugee status. And there are also a lot of things in the courts related to whether domestic violence might be a way you could be a refugee, or being a sexual minority. We tend to identify certain countries and certain conditions that let people under refugee status. So let's get to healthcare. Why don't we do the last one? Traditionally, refugees become refugees because of warfare, and their village might have been destroyed, or they've been threatened, or somebody might be trying to detain their teenage son to enter the army, and they travel to refugee camps, oftentimes far away. And by the time they get there, people are often malnourished. There's a lot of crowding. The water supply may not be great. There might be more people than the toilets can handle. And people get pretty sick in the refugee camps. A lot of people are unimmunized in the past. And we used to see, we were one of the refugee health screening sites in the 90s, early 2000s. Now it's only the health department because of the reduced number of refugees. And people would come with their little health record, and it would be a business card. And it might have a few immunizations on there. It might say cholera and the antibiotic they got. Sometimes it was in French, depending on who was running the medical facilities in their refugee camp. And then they would come to us for refugee screening, which is almost entirely about infectious diseases. And everybody got screened for tuberculosis. And in the course of my career, I saw tuberculosis in every organ of the body, and most doctors aren't allowed, don't get the pleasure of learning all those things in the adrenal glands, in the bones, everywhere. Tests for stool, ova, and parasites, because a lot of people have worms or other parasites. And then to figure out immunizations due, and oftentimes that's a long series of things because they may have just gotten the very basics in the refugee camp. I think family planning has been one of the most, something I'm pretty deeply invested in. And that's because people come from countries where they oftentimes have 10 or 12 children because half of them die. And for the long discussions we have with people about spacing their pregnancies, how much it would help their own health and their family's health, can be a difficult conversation. For instance, the Somalis that we've seen since about 2000 firmly believe that children are a gift from God, and they are. But one of the ways you can help your surviving children is have a little space in between. So you never talk about birth control, you just talk about spacing. Women who have delivered babies every year never recover their nutritional status, they never get their iron stores back, their vitamin stores. It places their next pregnancy at risk. They might have a miscarriage, they might not get pregnant, they might have a neonatal death, they might have a maternal death from postpartum hemorrhage, from infection, because they're just not in the state they should be to get pregnant. It definitely affects child mortality. If you have 10 children and there's only so much food, some of them are going to die. It the economic effect of the fact that the mother can only take care of children and can't do extra things for cash, like washing or embroidering. A lot of my patients did all the little embroidery things you buy at the market, the pipe market, means the children have a poorer health status. And one example of how ingrained the idea is of neonatal death is my Hmong patients, both my Hmong and Mien patients used to invite me to a lot of ceremonies. I went to a lot of funerals, I went to a lot of baby namings. And the Mien patients, and I got probably 5 of these as baby gifts for my children, embroider a little hat with a pom-pom on top for a newborn baby, and the baby must wear that all the time. And that is because as animists who believe the spirits of dead relatives or of the mountains or spirits in nature are coming to get their child, for their child to die, will mistake that child for a flower because of the little red pom-pom on top. And they, like many populations, wait a long time to name their child for the same reason. Like, this child's at risk. You don't know if it's going to survive the first week. You wait till 2 weeks to name that child. As you can imagine, people who have left their homeland under terrible circumstances, traveled, lost family members in war and from starvation and diarrhea along the way, measles in the refugee camps, you just sweep through. Now the immunization status is people's better, are pretty traumatized. And with my experience with the Cambodian population was that people often presented with very bizarre symptoms that I could not understand, like they were numb all over, or they would just drop to the ground and lay motionless and unresponsive, or would hyperventilate until they got muscle spasm. And it probably took me years to understand how that related to the trauma they'd been through. Many developing countries don't have a mental health system, they don't believe in mental health. People will often have very somatic or bodily symptoms to tell you how traumatized they are. And we had a wonderful program in our West Seattle clinic where the Cambodian ladies got together for a quilting group. Mm-hmm. So the acceptable treatment is all about social support and not about individual counseling. And there's a wonderful organization in Seattle called Asian Counseling and Referral Center.
Asian what?
Asian Counseling and Referral Center, ACRS, located in the Rainier Valley. Also has, operates under the same principles about getting elders together for lunch, just social support, no individual counseling. I also found that it was extremely difficult to figure out if people were psychotic using an interpreter, because sometimes people would express things that were cultural norms, and I didn't know if that was a cultural norm or if that was a delusion. And that's where the language interpreter and sometimes the staff could be cultural interpreters for me to know if expressing that or how they expressed that, whether that was acceptable in their community or whether that was way outside the norm. And then there's a lot of current research about the generational impact of post-traumatic stress disorders and how that affects family dynamics as far as domestic violence, child abuse, child neglect, because the families during my era caring for the Southeast Asian refugees always included a family member who was very severely disturbed. And that's what the child learns as a norm. And then finally, untreated chronic diseases and sequelae. In most countries of the world, the idea of prevention doesn't make any sense. You only go to the doctor when you're sick. you go to the doctor, you're really sick, you should get a shot because that's very strong medicine. And I'm just, this is like way across all Asian, African populations I've seen. It's just the way you do it in the village. And so the idea that you have high blood pressure and need to take a medicine to prevent things just goes nowhere. When people have not had any education, and the Hmong and the Mien never went to school ever, didn't understand physiology, like what the high blood pressure would do to your kidneys or your brain. And that resulted in my early practice of a lot of people getting like amputations from untreated diabetes and going into renal failure for untreated hypertension, and the idea of dialysis, like not okay. For instance, the Hmong have a very firm idea about the intactness of the human body and the 30 or 33 spirits that live in your body, most of which are in the head, which is why you don't ever touch a Hmong child's head if the family is traditional. And the idea that you would enter the human body and take something out with dialysis would obviously like totally do something to the balance of those spirits. Our Somali population also not very interested in interventional things, and especially the whole month of Ramadan, you can't do anything interventional. And I think I am done with my talk. Does anybody have questions? Yes?
I have a question about like health concerns, like how big is like STD? Like,
you know, that's
concerns
actually on the refugee screening list from the World Health Organization. And there are entire countries where HIV and hepatitis B are endemic. So that's, I should have mentioned that in infectious diseases. So when you do a refugee screening testing, you do all the types of hepatitis, HIV screening, you do urine for gonorrhea and chlamydia, syphilis testing.
Okay, and do you see a lot of that like coming in after that, like at your clinics, or is that not?
All of our clinics have a very high STD rate. I'm not sure I could break that down by populations. It's very interesting if you do epidemiology that there are STDs that stay in particular sexual cohorts. Like the North End may only have chlamydia, but there might be a lot of gonorrhea in Green Valley. Or syphilis in gay men population. The hepatitis B thing was huge in the 90s because the hepatitis B vaccine was very expensive and was just under development, and so we were only supposed to immunize children at risk, and that was almost always our Southeast Asian refugee population because hepatitis B is, I don't know, 20 to 40% prevalence in certain countries in Southeast Asia, and when you get neonatal transmission, you're much more likely to have a more severe disease leading to liver cancer and cirrhosis. And then certain countries in Africa have very high HIV prevalence.
What about hepatitis C? Did you see much of that?
Hepatitis C, I mostly see Americans with hepatitis C. Yes?
I'm curious more about your work with the homeless population and how that compares to working.
The homeless population is just so much fun. I just have so many stories I could tell. But I just recently realized that the surviving trauma part was a really strong link for the skills I had learned doing refugee medicine, taking to homeless medicine. I always ask people permission to touch them. Always giving people choices and letting them say what's culturally appropriate or what's acceptable to them. Although in the refugee population, sometimes they were so used to the doctor being an authority. In fact, in Vietnamese, I was Ba Bak Se, which means elderly lady doctor. and so some populations are used to the doctor just saying, like, oh, you get, take this,
the very strong power relationship, and some of the populations were so upset that some of our doctors and nurses didn't wear white coats because they weren't sure if they'd seen the authority. So that's a little bit of a difference. But like the Hmong population, they had very clear preferences, and so now when I do homeless medicine, everything is a choice. There's a lot of negotiated plan together about what will happen next. One of the principles of homeless medicine is a self-management goal. Like people who have become homeless often are not very socially integrated, often have kind of oppositional things towards the government and the police and the health system, and so if you were just to say do this, they just do the opposite. So it's always like, well, your blood pressure is this high, what would you like to do next? What's worked before? How can I support you? So a lot of the principles helped me because of the effects of trauma. People who have been traumatized are just not trusting. If you don't make human relationships, if you don't trust, you won't get as hurt when things get broken.
So what led from your shift? Was it funding from refugee help to
Well,
homeless?
there aren't as many refugees as there were in the 90s and early 2000s. I also like the freedom doing homeless medicine. One day a week, I wander around downtown with nurses, go to shelters and permanent supportive housing. It's fun.
Are most of the refugees, would you say, homeless people from the Vietnam War, would you say? Or
Homelessness is a fatal condition, and so it's a fatal condition. So there are a lot of vets who are homeless, but all the Vietnam vets who were homeless have died because the average life expectancy is in the 50s when you're homeless. So the vets we see are from the Iraq War, for the Gulf Wars.
Do you know the group called Women in Black?
Yes,
Yeah.
I have stood with them in the Westlake Mall.
You want to share?
Yeah, so Women in Black includes a lot of women who are homeless who show up to honor homeless people who die on the street. They do vigils at Westlake Mall, and they also are involved with memorial leaves, both at Pike Place Market and at the park in Ballard across from the library. And St. James does an annual memorial service, and St. Mark's reads the names during the during intercessory prayer of all the homeless people who have died in the past month.
Because I'm on the prayer chain for St. Mark's, and so I get every so often a list of the people who have died.
Yeah.
And the causes of the death. Yeah, but not in terms of the homeless on the streets.
Well, I mean, when it's cold like this, people die of exposure. I had a patient who had a throat cancer eroding into his neck vertebrae in a wheelchair because of a prior stroke, who died in an alley across from the clinic. Of course, there's more to the story because he kept leaving the hospital because he was mad about this and that. So it's always very complex. But, terminally ill and living in a wheelchair now.
And I read a lot of causes of death are cited as meth.
Meth. Oh, I hate meth. There's a lot of drugs in Seattle right now. They're very cheap. So about half of what I do doing homeless medicine is drug treatment. And especially there's some wonderful medicines to treat heroin addiction. But there's nothing to treat methamphetamine use. And it just makes people very anxious and paranoid and crazy, and makes your blood pressure and your heart rate go up. It's supposed to be a fun drug, but people don't look very happy to me. Yes?
When you're having conversations with patients who don't understand physiology or have the background to understand why something could be harmful in the future, how do you navigate that?
It's really hard. At one point, an interpreter and I did a high blood pressure series of group visits so that people could talk about their high blood pressure, and we could show them the measurements, and like do a little physiology with a long balloon about how if you squeeze it here, it makes more pressure over there. Absolutely failed. People thought, some of them who were old people and had brought grandchildren, a bunch of them brought food, it was all terribly salty, and they thought the balloons were there to amuse the children. So, what we did with those group visits is we did like 3 principles, and then later I did like a post-test during their visits to see if they could remember any of the 3 principles, and they couldn't. So total failure. Many of those people took their blood pressure medicines to please me. They liked me.
Any success stories with some homeless patients?
Oh yes, many, many. You know,
I'm sure the measure of success is very.
yes, so the another homeless principle is called harm reduction. That means people are doing very, very harmful things to themselves, and if you can make it just even a little bit less harmful to stabilize them, then that's success. And I think you'll appreciate this. Most homeless healthcare is done by nurses, and that's a beautiful level of care, because they all hate the doctors. Like they went to Harborview, they didn't get their narcotics, they got treated bad, it was cold, they laid on the gurney, they just hate doctors. But their nurse is their nurse, they love their nurse will take them to an appointment, their nurse will help them with their medicine, their nurse will sit on hold with HopeLink, which is how you get to your appointment for an hour. And so that's on a global scale, the huge success, which is the homeless people who are associated with the nurse have a much better health outcome. They don't go to the emergency room as often, they don't get admitted to the ICU immediately, they just cost the whole system much less, and they're healthier and happier. I'm trying to think of a specific success story.
Well, see, in terms of dealing with homelessness, I think Seattle had one of the largest homeless populations. I don't know how it relates, but it is large for a city, particularly. I think it's the wealth that we have here. So there's a lot of efforts to do it. And there was one program that was downtown, I think the guy did it for 40 years, where it was, he provided housing.
Oh, yes.
And then, but you didn't have to be,
Oh,
alcohol free. I mean, come in, we'll give you a place over your head, and then we'll start to provide social services and, try
Exactly.
Yeah.
So Seattle has a plethora of nonprofits who do permanent supportive housing for the homeless. These were all started as church shelters. So Downtown Emergency Service Center started in First Methodist Church, Plymouth Housing started Plymouth Congregational, and now they're huge housing providers. They get grants, and my own organization often co-writes the grants with them, because just housing people improves their health outcome dramatically. It can take a long time to get housed because you do this long intake, and it depends on how old you are and your risks and how many times you're in jail and in the hospital, like how much you use services puts you higher on the list. Because the minute you have housing, you don't use those services. People just go to the ER just to get warm. Or they're so miserable, cold on the street, they're using more drugs, and then they end up in the sobering center. Or they do something wild while they're on meth, they get arrested and they're in jail. So it uses the system a lot, and the minute they're in housing, things are better. But very well proven. Seattle was the pilot proving that this worked.
What was the name of the chap? He retired.
Oh yeah, that was, and then he died, I think too, yeah. I'm trying to remember his name. But he was with Plymouth Housing.
Was it? But that was an amazing story.
Right.
It really demonstrated the effects of housing.
Right. So some of these studies were published in the Journal of the American Medical Association 20 plus years ago, that if you house people, you can let them drink and drug as much as they want, as long as they're not attacking the staff or their neighbors, and their health outcomes are better, their cost to the city is so much lower. And there's a lot of outrage about it because many people consider these people like not worthy recipients of aid, like why are we giving them housing? But if you even look at it economically, it saves us all a lot of money. And I personally like all these people, so I think everyone deserves housing. Housing is a human right.
Jennifer, housing. Do you know, are you keeping up with what's happening? Is Amazon going to give,
Amazon,
give money for housing?
yeah, in the South Lake Union District, had an old office building or something they were going to demolish for their large campus, and they let Mary's Place, which started as Church of Mary Magdalene in the basement of, I can't remember which church, for moms and children and families to use that as housing. And then when they were going to demolish it, there was a lot of uproar and so as they built the new building, there's part of the building that is still a Mary's Place shelter. All right. Well, I thank you all for your attention. Go to Ballard and see some homeless people.
Yeah. And you work at St. Luke's over there too?
Yeah,
Yeah.
yeah,
And they have the feeding program.
yeah. St. Luke's does great things.
Located well.
Yeah.
And the library is sort of like a,
The library, a lot of the Ballard homeless hang out in the library. They go directly from breakfast at St. Luke's, hang out at the library, and then sometimes there's a little day shelter in there called the Bridge that they'll hang out and watch TV in the afternoon.
in the library.
No, yeah, at St. Luke's.
Oh, at St. Luke's,
Yeah.
and then they go to the park.
Yeah, the nurse and I go there once a month and just do health screenings and flu shots.
Because the library really has to accommodate you.
Yeah, and there's some other cities doing pilot programs with nurses, homeless nurses in libraries.
Oh, really?
Yeah.
It was really interesting because I live in Ballard, and the AT&T store was on the corner,
Mm-hmm.
of Market and 24. And there was an African-American gentleman there who was an employee of AT&T. And he had a whole ministry of people who would come in and talk to him. And he would listen to them, and he just was so good. And then AT&T moved, a couple blocks away. And so I said to Rob, I said, did your clientele follow you? But it was so close to St. Luke's, but he did a wonderful job.
Yeah, it's hard for communities when our clinic is in a building run by Compass Housing, which is a branch of the Lutheran Church, and there was a lot of uproar in Ballard because people didn't want homeless housing there. And it is true that people deal drugs in the alley, and there's needles on the ground. But then the case managers organized a day a week where they all go out with those little grabber things and pick up the needles. Yeah.
So where does your funding come from in terms of the neighborhood health organization that you're with? Lots of places?
It comes from lots of places. We're a federally qualified health center, so we get federal money. We get city money, county money, private grants.
But you're not part of the health department?
No,
Not
there are,
But you're-
in Seattle, all the community clinics are private nonprofits.
You have a board?
And we have board of directors here.
Yeah. How big is the board?
12 people?
And how many people would you say are working in the clinics?
Oh, we have over 700 employees. We're the largest provider of poverty dental care in the state of Washington. We have about 25 school clinics. We have 11 medical clinics. And we have 20 homeless nurses all over downtown.
Too bad. We have Bex, who's a nurse, nursing student. Too bad she's not here.
Oh,
And
well.
we had a student from Eritrea, she's not here.
Oh, too bad.
Yeah.
Because I worked with an Eritrean doctor in the early 90s who was one of 2 Eritrean doctors in the world. And he went back and he worked so hard he died of a heart attack. After Eritrea won their independence.
Thank you.
All right.